I will be talking about why sleep is such a big deal with autism. I'm Debbie Bilder. I am a pediatrician, a general psychiatrist, and a child psychiatrist, and I'm a professor at the University of Utah, affiliated with the Huntsman Mental Health Institute. These are my disclosures as I do consulting work with the pharmaceutical industry. Most of this involves things completely unrelated to autism, although the sources of distress I will be discussing in this talk, and that is copyrighted by the University of Utah. So I don't own it, but I was part of its creation, as was Dr. Davis, Heather Davis's husband. And I am also the founder for Zero. So what we'll be discussing is what happens during sleep, why sleeplessness stresses us out, and how sleep disturbance and autism go together, and how to fix the problem, sleep problem. So if you think about a sleep-deprived child, it really is amazing to think about the breadth of symptoms that child will have simply as a result of being sleep deprived. And I say this for children, but I can speak as to myself as an adult that I am also tired and irritable. I don't know if I would say I'm hyper, but kids definitely are. But I might be more hungry and want a snack to stay awake. And I definitely won't function as well in the daytime when I have not slept well. And so these children who are struggling with sleep problems really struggle across the board. And one of the main distinctions between how they look when they're sleep deprived and how we as adults or even adolescents look is that you can see hyperactivity instead of excessive daytime sleepiness. I want to go a little bit into what exactly happens when we go to sleep, because it has a lot to do with, what do we do about having problems with sleep? So this is our brain, and this is the eye, and here's the retina. That blue is the retina, which is the back of our eye, which perceives light so that we can see. And then it goes right into the brain. It's actually part of the central nervous system, the retina. And this clock is our circadian rhythm. Of course, we don't have a clock in our brain, but this is representing the suprachiasmatic nucleus, which is what creates a circadian rhythm. And this is our pineal gland. These are the three actors here that are inside us. And it all starts and ends with light. Light, when it is shining, will then be perceived and activate the back of the eye, which is the retina. When in the setting of that light, when the back of the retina is seeing that light, it will halt the suprachiasmatic nucleus, the circadian clock. It will halt it. It will say, hold off. However, at the end of the day, when the sun goes down, so goes away the halting of the suprachiasmatic nucleus. And when there's nothing holding it back, this is what it does. It then tells the pineal gland, all righty, release melatonin. Brain, soak yourself in melatonin and go to sleep. So I think the picture here is it starts with light. The light actually has an inhibitory effect in that as long as there's light outside, that suprachiasmatic nucleus, that circadian rhythm is being halted. It's being held back. It's not allowed to do anything. Until that light goes away, there's nothing holding it back. The gates go open and out the door goes the melatonin. Light is the major regulator of their circadian rhythm, their circadian clock. And the summer solstice, as a result, because the summer solstice is when we have the most light that we are going to perceive within a 24-hour period of time from the sun, it really does challenge mood stability in the context of bipolar. In the context of our clients who have a neurodevelopmental disorder such as severe autism, their brains are particularly vulnerable to extensive periods of light when it may not affect us and our ability to sleep, particularly if we don't have a serious mood disturbance. These folks can be particularly sensitive to having this extended exposure to light all day during the summer solstice. And for those individuals with bipolar disorder, this is often when they may experience a manic episode. For those of our folks who have severe neurodevelopmental disability, like I said, this is kind of when we might see that, particularly if they also have bipolar disorder as well, manic depression. Here's the picture, is even if the rest of the room is dark, like whatever time of year, if it's bedtime, even if the rest of the room is dark, if you're looking at a light emitting screen, like your cell phone or the TV or your computer, or whatever, like if that screen is emitting light, it doesn't matter what darkness is around you. If you're looking at it, your eye's looking at it, and the back of your eye is perceiving that light, and that light has a dark side. So that blue light is perceived like regular light, and it will be as if the sun didn't go down, even if it really had gone down. And so it's not so much what's around you, it's what your eyes are perceiving. And so that is why, there's your cautionary tale of, even if the rest of the room is dark, if you are looking at a light emitting source, well, it might as well still be light. outside for your brain in regards to sleep. I really want to emphasize how sleep is a dynamic process. I know that we go to sleep and then, we're asleep for 8 hours, hopefully, and then we wake up. Maybe we may remember a dream, maybe we don't, but it's almost as if we're like resting, right? That's not what happens to the brain. As you can see, it is a very dynamic process. So we may be consciously asleep, but as soon as you fall asleep, you start falling into the deeper stages of sleep. So stage 1, 2, 3, the deepest stage is 4. And you can see at the beginning of the night, there's a lot more stage 4 sleep because blue, unfortunately, you can see that stage 4 sleep is down here a lot more at the beginning of the night than at the end of the night, where that is not where you are. You're further up here. Also, you can see that REM sleep. You go down and then you end up cycling back up again, and then you have REM sleep, which is your dream sleep, and then you cycle back down again to stage 4, and then you go back up again. You can see that red, the REM sleep just gets longer and longer. You get more REM sleep later on in your sleep. So, earlier mornings is where you get a lot of your REM sleep compared to the beginning of the night. Rather, that brain is going to grasp onto that stage 4 sleep, that deep sleep, and just get it as soon as it can once you fall asleep. But this is a cycle that is going on throughout the whole night, and during this time, your brain is restoring. It's absolutely critical for your brain to function well in the daytime. So the purpose of sleep is to restore our brain's ability to think, and that happens as our brain cycles through the different stages of sleep. During that time, our memory is consolidated, so we remember things better. It keeps our mood stable. It regulates our emotions. And believe it or not, it helps our cardiovascular system. There's a very clear link between the health of our heart and our heart health and how well we sleep. They are just intrinsically linked. And it also affects our immune system. And so a good night's sleep is just essential to manage daytime stress and so much more. And the reason why it's linked to all of this, as opposed to just being sleep and maybe even just being the brain, is because it's linked to cortisol. So cortisol is our stress hormone. Our body releases cortisol when it is stressed. And as you can see, if we have a stressor, it sets off, this is our brain up here, it sets off our cortisol response. I won't go into the details. And then that ends up affecting our immune system, it affects our heart, it affects our liver, it affects our musculoskeletal system. It really does affect your whole body. What is up with this link between cortisol and the sleep cycle? Well, so it turns out that just like we have a circadian rhythm with the melatonin release at the end of the day, we have a rhythm in regards to our body's cortisol response. And as you can see, while we are asleep, right here, that cortisol in our body starts rising, and it peaks within about 1 hour of waking up. That is when you have your morning awakening response. It peaks about 1 hour after you wake up. And then slowly, it's bumpy, but you can see slowly it's making its way back down to the nadir, what we call the lowest amount of cortisol in your system. And you can see that's when it circles back to here. So when you start sleep over here, it's at its lowest point. And then it's going to slowly rise to sleep until you hit, or after you wake up, and then it's going to make its way back down. The difference between the peak, which is right up here during your awakening response, and the nadir, the lower part, which is all the way here, that difference, the higher that peak is compared to that nadir, the more distance, the more robust that cycle is, as opposed to just being a flat line. Generally speaking, the healthier we are. Your body is supposed to have a really nice, robust cycle. There's supposed to be a significant difference between the peak in the morning and the level it is at night. What we found is for individuals who are depressed, which is in red, you can see that overall it seems to be a higher line. You have higher amounts of plasma cortisol. In reality, I just want to point out that these little spikes up here, they go in both directions, and there's a lot of overlap right here. So with the peak, the peak that we talked about, there's a lot of overlap. The peak is very similar when you're depressed as when you're not depressed. Where the difference is it doesn't get down as far. It doesn't get down to that nadir. Like over here, you just don't get down as far as where you need to be to show that really nice, robust rhythm. So it's not so much the peak, it's that you just don't relax enough, or whatever you want to say, to get that cortisol low enough to truly get that nice, robust distinction between, awakening response and your nadir before you go to sleep. Turns out it is not a coincidence that the cortisol, which by the way is our stress response, the cortisol is the key to our ability to manage stress, period. It turns out it is not a coincidence that the cortisol, which you can see here, it drops until it's time to go to bed, and then it goes up while we're asleep, and then it drops. Here's your awakening response, and it drops down. It's no coincidence that's a 24-hour cycle, because in melatonin, it's peaking really our melatonin is peaking in our system in the middle of the time we're asleep. It's peaking near the nadir of the cortisol. So basically, the cortisol cycle is almost like in direct approximation to the opposite direction to the melatonin. So the way the cortisol cycle goes is linked to the way our circadian rhythm goes. In other words, if you mess with your circadian rhythm, if you mess with your sleep, you will mess with your stress response. And this is a study that showed exactly that. This is looking at shift work. So, some individuals work in settings where they will go from being asleep, like many of us, from 11 p.m. until 7 a.m., which is a typical day for many folks. They will shift from having a typical schedule where they sleep at night and they wake up in the daytime. Once again, here's our cortisol. Remember, it drops to its lowest just as you're about to fall asleep. It gets to its highest shortly after you wake up. It bumps its way back down until eventually you go to sleep, and it's at its lowest again. When you take that same individual and you say, no, you can't go to sleep at 11 p.m. We're going to keep you up. We're going to keep you up until that next morning at 7 a.m. and then you can go to sleep. Like shift work. Some people do factory work. They may shift from like graves to, mornings. When that happens, take a look. So this is the time when they're asleep. Instead of falling asleep from 11 p.m. to 7 a.m., they're sleeping from 7 a.m. to 3 in the afternoon. Look what happened to their cortisol rhythm. Just flattened out. And as I mentioned earlier, that's not good. You're not supposed to have a flattened rhythm. That is not healthy. Your body's supposed to have a nice, robust rhythm, peaks and valleys. You can see, this is day 1. By day 3, you can see, wait a second here, we're seeing a nadir here right before you go to sleep. And kind of maybe you're hitting a peak right there. You can see it's beginning to rhythm again. It's beginning to fluctuate again. By day 5, take a look at it. By day 5, this individual is still sleeping from 7 a.m. until 3 p.m., but now his cortisol rhythm looks just like it did before we messed with his sleep. So after about 5 days, your body will recalibrate. So if you mess with someone's sleep, you are completely going to mess with their ability to manage stress, their cortisol response, and yet you can stabilize it again and keep it stable and let them have restorative sleep. And I usually use as a ballpark about at least 5 days. Then you can see that you get that rhythm back. The rhythm comes back. This is a much healthier individual than here in the middle when their circadian rhythm is off. So they are intrinsically linked. So when both are messed up, if someone's stress response is awful and their sleep is terrible, the easiest thing to do is to fix the sleep. I don't know how I'm going to fix a cortisol release. I really don't, because it's not like we're trying to keep a level at a certain amount. You have to have this nice, robust shift. There's no easy way to make that happen in the way that the body's expecting it. The easiest way of doing this is to fix the sleep. And I know it sounds like that doesn't sound easy to you, but that's really where you start. We're going to be talking about how to do that. That's why I always start with sleep. If as a psychiatrist and a pediatrician, if someone comes to me and they're agitated and they're distressed and they're uncomfortable and they're upset and they may be self-injury or injuring others, if they're not sleeping, that is the first thing I do is I make sure that they are falling asleep and having restorative sleep consistently night after night. That is the beginning. I will not move beyond the topic of sleep until restorative sleep has been achieved consistently. So even though what I chase to try to help that individual sleep at night, whatever I think it is that's causing their sleep disturbance, the primary purpose of what I do to treat that is to make sure that they start falling asleep and staying asleep consistently every night. So no surprise to all of you, but sleep disturbance is very, very prevalent in individuals with autism spectrum disorder. About 60, which I think is a very low ballpark number, to 86% of children with autism have insomnia, difficulty sleeping. This can be of all different flavors. It can be a delayed onset, so it takes just forever for them to wind down and go to sleep. They just can't just fall asleep. It may be that they're waking up intermittently throughout the night. It may be that they wake up really early and they cannot get back to sleep. So insomnia really can involve a lot of different types, or timing maybe I can say, of sleep problems. But regardless of what flavor it is in that regard, if those kids aren't sleeping, their parents aren't going to sleep. And this is going to create a tremendous degree of stress, not just for the child, but for the parent too. And so once again, it's just so important to ensure that everyone in that household is getting restorative sleep so that they can handle just all the challenges that they face in the daytime. particularly as a result of the disability. So when it comes to addressing sleep disturbance, for me, it always starts with the causes. And as far as autism goes, it could be behavioral insomnia, and we'll talk about some things that can be looked at in regards to the structure of bedtime and the habits surrounding bedtime, and we'll talk about that, but that's a possibility and something to address. We see an increased amount of gene abnormalities related to our circadian rhythm in kids with autism. We can't fix that, but we can address it. There is an abnormal melatonin release in many kids with autism. So that nice melatonin release that you saw me depict in a neurotypical individual is not necessarily how our kids are having their melatonin release. They have a really hard time with arousal regulation and sensory regulation. And so it might have to be super, super quiet. Like, it might not take anything for them to be woken up out of sleep or to be distracted and they can't fall asleep. Or maybe they just in general can't regulate their arousal states. They get really agitated or really hyper, or they just get really subdued. These things really are going to make it hard to achieve a decent sleep state. They can have stress in their life. They're stressed. They can have sleep apnea, which means that they are stopping breathing in the middle of the night, just briefly, but it messes with their sleep quality. They may have seizures. Our kids who have moderate to more severe intellectual disability do have a significantly increased rate of having seizures, and seizures often occur at night. They may have something called restless leg syndrome. It could be discomfort. I have seen kids who will wake up in the middle of the night who ultimately was because they had gastroesophageal reflux, or they had constipation with cramping, or maybe something else is hurting them. Maybe if they have cerebral palsy, they're having some spasticity. As a psychiatrist and a pediatrician, I really focus a lot on the psychiatric and medical things that are contributing to sleep disturbance. I always talk about the behavioral aspects as far as the patterns and the habits surrounding sleep, but in reality, by the time I will have a chance to meet a child or an adult with autism who's having a significant sleep disturbance, that people have already looked at. That's been something that the family has been working on. I'll review it, but often they're aware of these issues and they have tried to do what they can to address them. Psychiatric comorbidity is such a common cause of sleep disturbance. At least 70% of kids and adults have at least one psychiatric diagnosis. Regardless of sleep disturbance, at least 70% will have at least one additional psychiatric diagnosis besides autism. So really common. And in particular, ADHD and anxiety are really present. But there's also some folks have depression, some folks have bipolar disorder, some kids and adults may have psychosis where they'll hear or see things that other people cannot hear or see. And it's very common to have multiple psychiatric conditions. And each one of these can really affect a child's ability to go to sleep. The challenge about these psychiatric conditions, because if we're trying to address sleep disturbance, you've got to address the cause of the sleep disturbance. And with so many kids having these psychiatric conditions, I'd like to think this is just because that's who comes to see me, but these are studies that are population-based studies. So these are studies that weren't about someone going to a doctor and being assessed and identified with a psychiatric diagnosis. These are folks from the community who were assessed separate from a clinical setting. So the challenge is identifying if they have a psychiatric disturbance when our folks really have a hard time describing their thoughts and feelings or their worries, or just describing what's wrong, what hurts, what's uncomfortable. Our folks who have limited use of meaningful language, whether it's a psychiatric issue or a medical issue, that problem can often be overlooked. And so over the many years that I've been practicing psychiatry, medicine, pediatrics, it has been clear to me that caregivers, parents, or professional caregivers, particularly for many of our adults, they live in group home settings or supported living settings where the individual who sees them most on a day-to-day level is a professional caregiver, or parents, particularly obviously for the kids. I would put parents and professional caregivers, I have found that they know everything they need to know to be able to help me figure out what's causing the agitation, what's causing the problem, what's causing the sleep disturbance. Like they know everything I need to know, and someone who doesn't have the language to be telling me about it. And if I knew what to ask them so that they would understand what it was that they knew that was relevant, so they may know everything, they just don't know necessarily what's relevant. And if it's relevant, well, in what way? What does this point to? But parents, I have found, really do fill that communication gap between their kids and me or their other providers in trying to figure that out. They truly act like translators. So as you can see here, I really think of when I work with caregivers and parents, this is the translator, help me understand the individual who I am taking care of who can't use his words meaningfully enough to help me know what's wrong, what's going on. And so parents really function like translators. So in order to figure out what's going on, I put a tool together called the sources of distress, and my team did. Also, Whitney Worsham, who is now a resident, a psychiatry resident at Dartmouth, and John Davis, who is one of our educational psychology faculty members. He's a psychologist. Put together this tool that's online that takes about 5 minutes for parents and caregivers to complete, and it asks them all the questions I would ask them if they were in the clinic seeing me. I would go through all these questions, and it goes through all of that. It uses branching logic to save families time. Because in other words, when you're asked a question and you answer a certain way, your next question depends on how you just answered. So if you say, yes, Johnny is having difficulty sleeping, then you'll subsequently be asked a ton of questions about his difficulty sleeping. But if you say, no, Johnny isn't having difficulty sleeping at all, you'll just be asked, when does Johnny go to sleep? When does he wake up? Is he waking up in the middle of the night? Does he take naps? That's all you'll be asked if you say that Johnny doesn't have trouble sleeping. But if you do say he has trouble sleeping, then we ask, well, is it that it takes him time to fall asleep? If you say yes, you're then asked questions about that. If you say no, you'll move on to the next series of questions. That's branching logic. The idea is to really minimize the questions that are asked to a parent or caregiver unless it's pertinent for them. It goes over domains of sleep. As you can imagine, it's a very, very thorough sleep domain. Anxiety, history of trauma or post-traumatic stress disorder, depression, mania, psychosis. It has a general physical area. We'll ask you questions about physical problems, and then specifically it will drill down into asking about your gastrointestinal tract, like reflux and constipation and bowel movement frequency. For females, it will ask about menstruation. If you're not female, you should not be asked that. And that's female sex, so that's biological female. If someone may biologically be male, but identifies is transgender and identifies as female, they will not be asked the menstruation questions because biologically that's not something that they're working on. So this particular tool does allow for the opportunity for someone to have their gender declared, expressed, so that we use proper pronouns and proper questions. And in addition to that, dental issues, very common issues that often get overlooked or not seen just because they're hidden back there in the mouth. This was validated in focus groups, including parents and affected individuals. It was reviewed by experts, it's copyrighted, and it's free to everyone. I bring this up and I want to just share the website. So I'm not going to go into a long story, but there were a lot of people involved to make this possible. The registry, the Utah Registry of Autism and Developmental Disabilities, ultimately ended up being that last link, so to speak, that made it possible for the website to be freely available to everyone. So to make a long story short, the university liked the tool, they just didn't feel comfortable with the liability surrounding like having a medical questionnaire tool, and the health department says, are you kidding? Like, we need this. And so we'll take that on, we'll contract with you, we'll take that on. And they posted this link for families to access this tool on one of their websites, and there it is. I can tell you the tool then links to a server that is HIPAA protected. So, protected private information is protected. So it links into the university protected server as it asks questions, so we appropriately protect people's privacy. So after someone completes this, I generate a report. I will send it to them. I will offer additional resources through the health department to let them know about. But if there are clear next steps, whether, for the sleep disturbance, like I mentioned, for outbursts, for mood instability, for whatever it came up with, if it really seems like there's clear next steps, and I have to say, we've done this over 200 times, I've looked at over 200 sources of distress, and I've yet to see one that there were not clear steps that it might be helpful for that individual's medical provider to connect with me so that we can talk about it. And so I always offer to parents to ask their provider to speak with me. This is called a Curbside Consult. This is of no charge to anyone. I feel it's part of my responsibility at the university, and I think the university deep down inside sees that it's part of their responsibility too. I just know that in my heart. And so I am available for Curbside Consult, so I can help these providers take great care of the patients who they know well and the families they know well and where they live, so they're not having to come to the Mecca, and just get those needs met and help that provider, so the provider doesn't have to be an expert to take really good care of their patients. They just need to connect with an expert like myself to get some guidance on what could be helpful in addressing this issue. Subsequently, the provider is able to reach out to me directly. So I do not give my cell phone number to families. My husband would not let me do that. That was one of the conditions of our marriage. coverage, but I am allowed to give, they do on occasion, and I'm happy to help, although often we've kind of got a good plan, and sometimes they get back to me and it takes us a little bit of time, but we get there. Whenever I've got someone who's agitated, who's distressed, who's really having a hard time, at the very top of my treatment hierarchy, when I'm handling anything where someone is having a really hard time in whatever manifestation, I start with sleep, and I don't go past sleep until that individual is sleeping consistently every night. It may be mania, bipolar disorder, that's causing them to have a sleep disturbance, and so I will then target that bipolar disorder, but I will target it with the medicine that will get them to sleep and get them to sleep consistently night after night. I will make sure what we start is going to get them to sleep. You treat the sleep, you may be treating bipolar along with that, or psychosis, and then you address other issues like anxiety and depression. If it's anxiety that's causing them to have trouble sleeping, we will be addressing that, but we will be addressing that, making sure they're also using something to help them fall asleep as we reduce their experience of worries. It is not uncommon for me to identify medical problems that are affecting sleep or just affecting in general how someone is feeling. It's very common. And they may be conditions that are on the forefront of the parent's mind, the provider's mind, or they may be conditions that actually had not necessarily been recognized as a problem. And this tool will help elicit a lot of that. And if we do identify a medical problem and psychiatric problems with sleep disturbance, we will do parallel processes. Like if we know there's a medical problem, we will recommend treatment for that. You don't need to wait to fix that, to be dealing with this stuff over here, which is psychiatric, because you treat them differently. And there's no reason not to just treat them in parallel, just to try to get as quickly to where well-being is and good night's sleep is as possible. So correcting sleep disturbance. So the Autism Treatment Network has a great sleep toolkit. It just got it addresses a lot of the behavioral sleep problems, behavioral insomnia, and it talks about something called sleep hygiene, as far as what environment do you create for your child, or what patterns of habits do you help your child to create to facilitate the greatest likelihood that brain is going to realize when it's night and they walk into their bedroom, it is time for sleep. That's the point. Just to pass off some of the really common things that are issues is making sure that you have a comfortable bedroom, in regards to temperature, in regards to it being quiet, in regards to it being dark. And, especially with those electronics, we've got to turn that off a couple hours before bedtime, because you've got to give that brain a chance to register that there is no light there, to keep the gate down on the melatonin so that the gate can go up, the melatonin can go out in time to get you to sleep. The biggest thing is to be consistent. You saw that cycle that I showed you, and you saw how it lined up with the hours of the day. Like pick a bedtime, just pick a bedtime and be consistent with it. If you're really staying up until 7 in the morning, and that is like when the child is up until, and they go to sleep from like 7 to, 5 in the afternoon, you want to fix that, because that is their rhythm. It's just not functional if they're attending the preschool, because they need to be awake in the daytime. And you can fix that. And the way you do that is you talk to your medical provider, and there's a specific way in which you phase shift back. And if your medical provider has never heard of this, I would be shocked. But if they haven't, by all means, have them reach out to me, please. And I would be happy to explain to them how to phase shift someone back. So not just for you, but for their other patients, they will understand how to phase shift, so that kids who are sleeping all day and awake all night can successfully phase shift back to sleeping at night and being awake in the daytime if they have the Pingree Center to go to and need to be able to take advantage of all that wonderful funded education that they're receiving there. Melatonin is made from serotonin in our brains. And it turns out that elevated serotonin is one of the most consistent biomarkers in autism. It occurs in about a third of individuals with autism. We have no idea why. We've known this for over 50 years. For over 50 years, we've known that about a third of individuals have autism will have elevated serotonin. We still don't know why, but I think deep down inside, it's not a coincidence when you consider the rate of sleep disturbance in this population, that the fact that melatonin is made from serotonin and the serotonin is elevated in a decent number of these folks, that there might be a coincidence in why we're seeing many issues with sleep. There is lots and lots of treatment trials, 10 plus, that support the use of melatonin, 3 to 5 milligrams, that you take about 30 minutes before bedtime. There are some very fancy ways of doing melatonin, like, start it at 6 and do another one. I really never recommend that. It's like, let's keep it really simple. Let's give you 3 to 5 milligrams, 30 minutes before it's bedtime for insomnia, for children with autism. However, The really important thing about the melatonin, I can't remember if I put it in one of my later slides, so I'm going to talk about it right now, is that there can't be anything in it. I can't begin to tell you the number of times when I have talked with families and seen kids, or even just heard of kids and helped other medical providers whose child has a significant sleep disturbance and they're using melatonin, but it turns out that they're using melatonin that has additional active ingredients in it that mess with people with autism. And they were put there on purpose because neurotypical folks may calm down from things, but not folks with autism. It will agitate them. Once they went back to regular melatonin and they got rid of their melatonin plus, melatonin extra, all I have to say, rather than go through the litany of things that can be added that will mess with kids with autism, let me just say, if you just use the regular melatonin, no additional active ingredients, of course there'll be fillers or something, but no additional active ingredients, you will be good. You will not find yourself in that situation. Exercise is good for sleep hygiene, but not before bedtime. Really try to avoid caffeine. I see this a lot in our community with soda, maybe less so with coffee, but definitely particularly soda after 12. I still would probably limit it to like one soda a day before 12. I don't think or coffee, one coffee before 12. It's not that I would go wild on how much caffeine I would recommend drinking before 12. I would really cut it off and say at 12, the individual is not having a caffeinated beverage. That may mean stocking the fridge with decaffeinated colas. That could be a nice compromise. If a child is used to getting their soda at 3 when they get home from school, they made the transition without difficulty, great, but just do the caffeine-free type. Comfortable bedroom, we talked about this, and then teaching your child how to fall asleep alone. So it turns out that we actually all wake up in the middle of the night, at least many of us do. If you recall how we go in and out of sleep, right? Stage one into the deep sleep, and then all the way up to REM sleep, which is the lightest sleep we have, and then down to the deep sleep and up to the lightest sleep. When we hit that lightest sleep, it's not unusual for us to wake up. It's just we don't remember it because we just go right back to sleep. We just don't remember waking up in the middle of the night. We just go back to sleep. A problem with kids who don't learn how to fall asleep without their parents right there is that when they wake up and their parents aren't there, they can't just fall right back to sleep. They can't fall back asleep. And so when you have a child who is waking up a lot throughout the night and you've made sure it's not seizures or it's not reflux or it's not pain, and there's nothing else the child's doing in the middle of the night. It's not like they get to wake up and no one's awake, and so they get to watch TV or they get to go play their games without anyone watching them. If it's really just they're waking up and they're miserable and they're crawling in to your bed to go back to sleep, I always ask, are they falling asleep on their own at night, or does their parent need to be there just to even be present? I think, we're likely to be there so they can kind of snuggle up or, rub their back or do something like that. It doesn't mean that you as a parent can't be part of bedtime. Of course, it's just a fun time for some folks if they're falling asleep, okay, to kind of connect with your child. But when your child is actually falling asleep, they need to learn how to do that by themselves. Otherwise, if they're waking up a lot throughout the night, it's because they never learned how to fall asleep on their own to begin with. When it comes to medicine, and I kind of alluded to this a little earlier when I said about what are they doing in the middle of the night when they're awake? Short of general anesthesia that you'll have in the operating room, there are no meds that will get your teenager to sleep if he, she, or they have something better to do than sleep. I have done this for 20 years. I can tell you, Ativan's not going to do it. The heavy hitters, the Prex is not going to do it. If they've got something better to do, especially if they have autism, they'll be so stubborn about it. There is no way you're going to get them to sleep if they've got something better to do. So a big piece of this is to eliminate what is competing with sleep. I know that's not easy because all those things that are competing kind of give us a break. I'm a parent of a child with autism. It's really nice to have my kiddo watching TV or playing some video games, but I just need a break, or maybe even more likely, I'm trying to get some work done, giving a lecture or talking to you guys. They're really nice to have that help. If it's available to them, they will not go to sleep if they want to keep on playing it. They won't, and they won't want to, and you can't medicate that. I often find combining medicine with sleep hygiene works well. What I mean by that is typically melatonin. And like I said, we already produce it. It's a natural substance. You buy it in your natural food part of your grocery store or pharmacy that I feel very comfortable endorsing because it's something that we all produce. And as long as it doesn't have other stuff in it, regardless of whether we produce that or not, then it really does help with sleep. So I will often recommend melatonin and whatever else makes sense from a behavioral perspective if there are things that are competing with falling asleep or that you need to set up some better patterns And then the medication that's selected, I alluded to this earlier, even if I do identify a psychiatric issue, I will likely use melatonin as well to help with sleep, just because those with autism often don't have a normal circadian rhythm, normal melatonin release. But for instance, if this individual has psychosis or bipolar disorder, I probably actually will not be recommending melatonin. There, I would be recommending like a mood stabilizing medicine that will make that is sedating as well. That will help them fall asleep, but with that eye on getting them to sleep. So it's really about, well, what's causing you to have trouble falling asleep. We'll also sometimes use clonidine. So if it just seems like they can't just shut it down, so to speak, like they're just super aroused and they just can't like just turn it off and let them go to sleep. But we're not talking about bipolar disorder, just a matter of just their arousal regulation. I'll often use clonidine just to kind of, interrupt that fight or flight drive and just let them go to sleep. Trazodone I'll sometimes recommend as well, but only in verbal. All females, it's fine as long as they're not have bipolar. But males, they have to have the language ability to their parents know if they're having a specific male-related side effect, and that's something that their doctor talks to them about. And then sometimes we'll also use mirtazapine, which is also an antidepressant, which you would not use in someone who's bipolar, but otherwise can be helpful falling asleep. There's meds out there, but I definitely have to say by far melatonin and clonidine are my go-to, or a completely different medicine that's treating something for which the sleep disturbance is very much secondary to, like a mood disorder or psychosis. So in the big picture, sleep and stress response are intrinsically linked, like physiologically, like we can track it, like as I showed you on the slide, like they are linked. They're just always going like an 180-degree approximation. And if you mess with one, you mess with the other. But you can use that to your advantage, because if they're both messed up, if you can fix that sleep, then you can really make a huge difference on their ability to tolerate stress in the daytime. Most pathologic emotional experiences are related to abnormal stress responses. So a lot of what presents to me are related to their difficulty managing the stressors of the world or the stimuli of the world. If you fixing a sleep disturbance is the ideal place to start. It's always where I start. A good night's sleep is the cornerstone of any effective sleep treatment plan. Melatonin, without any active ingredients, a definite go-to, 3 to 5 milligrams. So when I mention melatonin to parents who are neurotypical, they may or may not have had their own experience with melatonin, and very likely if they did, maybe it didn't do much, because it's just melatonin for them. And so they really, often like, oh, that's not going to do anything because it didn't for them. Our kids with autism are just different. Like they are far more responsive to melatonin than I ever see in the neurotypical population. It doesn't mean that it's definitely going to work, but I guess what I'm trying to say is if you haven't tried it and your doctor recommends it, or you just want to give it a shot, make sure it doesn't have any other active ingredients. It's worth a shot if your child has autism, because it's more likely it will be effective for them than it would be even if you've tried it in the past and didn't. The sources of distress, I gave it a full plug there, and I told you on the front end that I'm going to be talking about it. This is a free tool that University of Utah owns. It's copyrighted by the University of Utah. I neglected to give you the most important part of that story, and that is it exists because of the Autism Council of Utah. One of the leaders within the Autism Council of Utah a few years ago came to me, and we were just talking, and I was bemoaning the fact that I would give lectures in the community to the pediatricians and the medical providers about, how to identify depression and anxiety and bipolar disorder, and then how to treat it. And I think what I was bemoaning is that even though I try to teach folks how to do this, and I would see some change, I did see change in some of the prescribing practices. Ultimately, when the prescribers panicked, when there was a lot of agitation, they would just throw on an antipsychotic, for which there's nothing wrong with. Like, you gotta make sure there's safety, but it would end there. Like, they'd throw on the antipsychotic, but they would never figure out what exactly was that treating. Like, they would just keep it going without knowing. And I was just bemoaning that folks are showing up to my office who may or may not still be upset, many of whom are upset, and that's why they're showing up there. They're on all these antipsychotics. And what this parent from the Autism Council of Utah said was, don't teach them, teach us as a parent. We're the ones who really care. Now, of course, all those providers really care too. But what I heard that parents say is, look, we'll be the ones to spend 15 minutes filling this out. We'll spend 20 minutes filling this out. This matters so much to us, and we want to be empowered to understand what's going on with our kids. We put a grant in, my team, to the Autism Council of Utah for $20,000 and to develop and validate the sources of distress. And that's what we did, and that's why it exists today. And so I am greatly, greatly appreciative to the Autism Council of Utah to make that possible. It is now free to the public, thanks to the department Department of Health. The Special Healthcare Needs Bureau at the Department of Health took the step that you wasn't comfortable taking and said, oh yeah, we want this to be available, and we're not as concerned about the liability as the university is, because it's kind of like a medical tool. They're like, we'll post it on our website. Yeah, it's your tool and it will link to what you do, but we'll take responsibility for it. We want to provide a service to our families who are affected by autism. And I feel incredibly appreciative for them to make that possible so that our community can just get so much more understanding of what's going on. I just want to thank all the clients and families that we serve here at the Huntsman Mental Health Institute through my program at the home program. I still consult there, even though I don't really follow patients long term. I'll still get involved when there's a crisis. And I also wanted to, of course, put up a cute picture of my boys. This one's now a teenager, and I thought I would put up a picture when he was still cute, but I'm sure he'll be cute again. And I must want to give them some acknowledgement because there are ones downstairs who are probably still waiting for me to get dinner started. So I'm going to run and do that after I'm done with that. And this is done with this. And this is the Huntsman Mental Health Institute. It's our brand new institute. This used to be uni. I'm so excited to see where this institute is going to take mental health here in Utah. And I can promise you, I've been plugging very hard that part of where they take our state is prioritizing the mental health needs of our folks who have severe neurodevelopmental disabilities. And so we will see how their vision pans out, but they have been very receptive thus far to embrace the needs and responsibility of taking care of our folks too, along with our neurotypical individuals with mental health care needs. I'm going to end then with that link for the source of distress. I don't think I have my email address, but by all means, if Pingree they have my email, you are welcome to post my email. If you have any questions, I would like to be a resource for you. I can tell you if you have the sources of distress done, I usually don't talk to the parents, I'm talking to the providers, but on occasion I may reach out. But from a time perspective of what's most efficient for me is to take all this amazing information you give me. By the way, I send you a report. So you get a report that is written for you, not the providers. It's written for you to explain everything you said and how that fits into what me and other doctors should think about in regards to anxiety or depression. Like, you will have that and you can bring that to your provider. And then, like I said, I would be happy to talk to your provider. And any provider, medical provider who has time to talk to me, I will make time to talk to them, thus far. And I've yet to give up on that one yet. We'll see. This has been a system that I think has worked well thus far, at least on this small scale for our state, and trying to meet some of the needs that I know go very much unmet out there on helping kids and adults with severe developmental disabilities get their mental health care needs met, get their sleep disturbance needs met, even maybe in trying to figure out some of the physical stuff that just it seems to be perplexing people. This is the link to the health department, and Pingree is absolutely welcome to also distribute my email address. So email me with questions. Thank you for your interest.